All right, thank you everyone for the short break. We will now reconvene the ACIP meeting. I'm going to ask my colleagues in the room if they could please put up the slides for the influenza vaccine session next. We may have some modifications to this section as we are running 40 or 45 minutes behind schedule. So I am going to ask that we focus our questions and our discussion as tightly as possible, so you all will be able to get out at the end of the day. Today, we'll start with an introduction by Dr. Jamie Lair, who is the workgroup chair for the influenza ACIP workgroup.
I'd like to let everyone know that the presentations today and tomorrow are informational only. There will be no votes on this. These slides are going to be addressing topics that have been sort of ongoing questions, and they're going to shed light on topics which are going to be helpful for us information-wise going forward. Next slide, please. I'd like to thank everyone, the ACIP members, the ex officio members, the liaisons and representatives, and especially our CDC lead, Lisa Groskopf. Dr. Groskopf has been a wonderful leader for us and kept us on track, meeting usually twice a month to talk about all these topics. Next slide, there's also a number of CDC participants who have been very helpful in the discussions. The three major areas we're going to be talking about are influenza vaccines in pregnancy, co-administration of influenza vaccines with other vaccines in adults, and influenza B Yamagata. Next slide, please. The question we have is that we're very comfortable with the safe administration of influenza vaccines in pregnancies, but there has been less data on newer influenza vaccine formulations. And so we're going to have a presentation by Dr. Nikki Klein about the recombinant influenza vaccine in pregnant women and their infants, from Dr. Greg Sylvester about pregnancy outcomes with Flucelvax, and tomorrow we're going to learn a little bit about effectiveness of maternal influenza vaccination against pregnancy, against influenza-associated hospitalizations and ED visits in infants, which is a wonderful topic, from Ms. Samantha Olson. The next topic is going to be about co-administration of vaccines in adults. And so we have newer vaccines, and we have more information about whether those can be given safely with some of the standard vaccines that we're giving. So Dr. Chip Walter will be talking about simultaneous versus sequential administration of mRNA COVID vaccines and the quadrivalent vaccines. Dr. Ken Schmader will be giving a talk about Zoster Vaccine and influenza activated vaccine. And then Dr. Tom Shimabukuro will be giving an update on the COVID vaccine and influenza vaccine safety. Next slide. Of interest, you know that we do a lot of surveillance about influenza vaccines. Interestingly enough, influenza B Yamagata, there have been no confirmed detections since March of 2020. And so there has been discussion by the WHO and the FDA about whether it is still appropriate to have that in the quadrivalent vaccines. And so we'll have an update on influenza surveillance, influenza B Yamagata by Dr. Rebecca Condor tomorrow. And turn it back over to, I think it's Dr. Nikki Klein would be going first. Thank you.
Thank you.
Great. Great, thank you very much. Great, it's my slides. So today I'll just, thank you for the introduction, and as you mentioned, I'll be talking about the safety of quadrivalent recombinant influenza vaccine in pregnant women and their infants. Next slide, please. So just some disclosures, Sanofi provided research support for this study, as well as all the recombinant influenza vaccine for the study, which was 1.2 million doses, and then some other unrelated research support from other companies. Next slide. So since 2004, the U.S. Advisory Committee on Immunization Practices has recommended that all pregnant women receive an inactivated influenza vaccine during any trimester of pregnancy. And this includes recombinant influenza vaccine, or RIV, which has been available since 2013. However, there has been limited data regarding the safety of RIV during pregnancy. And so we conducted a post-licensure observational study to assess the safety of RIV4 during pregnancy. Next slide. So the setting was Kaiser Permanente, Northern California. As for those of you who aren't familiar, it's an integrated healthcare delivery system with an annual membership of over 4 million, and approximately 65% are aged 18 to 64. So members receive nearly all their care at KPNC facilities, which was 259 medical center clinics and 21 hospitals. We have an electronic medical record that captured all healthcare encounters, diagnoses, lab tests, vaccines, and medications. And then within KPNC, routine influenza PCR testing begins in early fall, and the flu PCR tests are ordered at physician's discretion. Next slide. So the primary objective of this study was to evaluate the safety of quadrivalent recombinant influenza vaccine compared with quadrivalent inactivated influenza vaccines in pregnant women and their offsprings. Next slide. So this study included all routinely influenza vaccinated pregnant women and their live-born infants at KPNC during 2018 to 19 and 2019 and 2020 influenza seasons. So all vaccinated pregnant women were a subset of a separate cluster randomized effectiveness trial, which compared the relative vaccine effectiveness of RIV4 versus standard dose of quadrivalent influenza vaccines against influenza and influenza-related outcomes. Next slide. So I'm going to just step back for a minute because I think it's worth to understand the study, just give a little context regarding the larger relative vaccine effectiveness study. This was a cluster randomized observational study of all KPNC adults vaccinated with either RIV4 or SDIIV4 during 2018-2021 influenza seasons. KPNC aimed to administer 400,000 RIV4 doses and 400,000 standard dose flu vaccine doses to adults 18 to 64 during each of the 3 seasons. To minimize geographic and socioeconomic imbalances between facilities and to achieve balance and covariance, we cluster randomized facilities within each of the 7 service areas to receive either RIV4 or standard dose on an alternating weekly basis. The randomization accounted for facility size, facilities within each service area, and the goal was to achieve balance and covariate distribution between those who received recombinant versus standard dose influenza vaccines. For example, similar proportions of RIV4 versus standard dose who were female. Next slide. It's a little. Next slide, please. So the design, I'm just going to walk quickly through the design because it's important for the current study, is to understand that the design of the RIV4 and SDIIV4 relative vaccine effectiveness studies. So as I mentioned, there are 7 geographic regions throughout KPNC. We randomized within Block A's or Block B, and then Block A or Block B, which was randomized for week 1 to receive either RIV4 or SDIIV4. And then each week they alternating so that every facility gave every vaccine on an alternating weekly basis. Next slide. So overall, the RIV4 and SDIIV4 RVE study included 1.6 million influenza vaccinated adults 18 to 64. Now the study ultimately only included 2 seasons through 2020 due to COVID-19 pandemic. Now the current study focused on the subset of vaccinated pregnant women and their offspring from this overall relative vaccine effectiveness study. Next slide. So the study outcomes were pregnancy outcomes, spontaneous abortion, preterm labor, stillbirth fetal death, congenital fetal anomalies detected during pregnancy, eclampsia and placental abruption, birth outcomes of preterm birth, low birth weight and small for gestational age, and then the neonatal infant outcomes through 365 days of life, and that included infant death, congenital anomalies, and failure to thrive. Next slide. So for a statistical analysis for pregnancy outcomes, we compared the odds of a pregnancy outcome among RIV4 vaccinated pregnant women with SDIIV4 vaccinated pregnant women. We used conditional logistic regression, which was conditioned on gestational age, and we adjusted for maternal factors, as you can see listed here. For the birth and neonatal infant outcomes, we compared the odds of birth and neonatal outcomes among RIV4 vaccinated pregnant women with SDIIV4 pregnant vaccinated women. And we used logistic regression that was adjusted for infant sex, race, ethnicity, maternal age group, and maternal trimester of influenza vaccination. Next slide, please. So here's the final study population of flu-vaccinated pregnant women and their infants. So for the two included seasons, there are a total of 54,360 pregnant women vaccinated at KPNC. After excluding for both the RIV4, there was 14,981 RIV vaccinated pregnant women, and there was in the infant cohort of the RIV4, there were 14,538. In regard to standard dose vaccinated cohort, there was after excluding few women, there was 33,800 SDIIV4 vaccinated pregnant women, and which included 32,856 infants in the SDIIV4 cohort. Next slide. When we looked at the demographics of the pregnant women, here you can see in the first column is RIV4, and the second column, SDIIV4. Here is highlighted that there is no difference between the trimester in which the pregnant women received their vaccines. And then also, when you look at the racial and ethnic differences, there were no differences between the two, or between the two populations as well. Next slide. So when we looked at the pregnancy outcomes, these are the results. We looked at the outcomes I mentioned earlier. You can see that the adjusted, none of the outcomes that we evaluated were statistically significantly greater than 1. We saw no increase in any of the outcomes that we were evaluating for the pregnancy outcomes when comparing RIV4 with SDIIV4. Next slide. So when we looked at infant demographics, you can see, again, there was no difference in the race between the RIV4 vaccinated infants and the SDIIV4 infants, vaccinated infants. And importantly, there was no difference in the preterm births for the gestational age between the two populations. Next slide. Now, when we look at the birth and infant outcomes, we did analysis. You can see that for the birth outcomes as well as the infant outcomes up to 365 days of life, there's also no difference between the RIV4 vaccinated infants and the SDIIV4 vaccinated infants for any of the outcomes that we evaluated in the infants. Next slide. So the strengths of the study is that all pregnant women in the study were a subset of a large modified cluster randomized relative vaccine effectiveness study of RIV4 versus SDIIV4, which included approximately 1.6 million adults. The RIV4 recipients were very similar to the SDIIV4 recipients with respect to risk factors for adverse outcomes. And this had fewer sources of bias than in most observational studies. Next slide. So study limitations. So there were slight imbalances in the timing of vaccination that might have been related to provider preferences. The proportion of pregnant women who received RIV4 during preconception or first trimester was relatively higher in the SDIIV4 group than in the SDIIV4 group. Historically, the OBGYN clinics within KPNC have been accustomed to giving SDIIV4 in pregnant women. So it's possible that providers prefer to administer SDIIV4 once the new individual was pregnant. However, since demographic and covariate factors were similar between the two groups, such slight imbalances were unlikely to have affected the analysis. Next slide. Now, in summary, within a large population of influenza vaccinated pregnant women, comparing RIV4 with SDIIV4, there are no differences in pregnancy, birth, and neonatal infant outcomes. No safety concerns were identified after RIV4 use in pregnancy. The proportion of pregnancies or live births with outcomes was lower than published U.S. rates for most other studies. And then the study provides reassuring safety data regarding the continued use of influenza vaccines in pregnant women. Next slide, please. I'd just like to acknowledge, this was members of my team, in particular, Amber Shaw and Arnold G. really took the lion's share of the work there, as well as our colleagues at Sanofi. Thank you.
Thank you. And this presentation is now open for questions. Dr. Paling?
So thank you for this presentation. This is important work, and I'm very appreciative of all that you've done for the safety. And the focus of this presentation was on the safety of the vaccine. Is there plans to also look at the effectiveness on preventing hospitalizations?
You mean in this population?
In this population, yes, both the pregnant moms as well as in the babies after birth.
Right. So the pregnant moms were all included for the most part, a few minor exceptions, were all included in our larger VE study, which are not, I have not presented those results today. So they weren't separated out as part of our relative vaccine effectiveness study. The infants, we don't have plans at the moment to do a VE study of the infants. We have discussed it, but there's nothing firm that we move forward with yet for the infants.
Okay, thank you. My second question is, do we know what percentage of pregnant persons were vaccinated in this population? Thank you.
I don't have that in hand. I'm going to look to see if anyone on my team has that information readily available. We can look for that and try and get back to you if we can find that.
Thank you. Ms. Hayes?
Yes, Carol Hayes with the American College of Nurse Midwives. I have two questions. My first is, I was really curious why 30% of the participants in the study had an unknown race.
Well, again, this is from an observational. This is from the data. This is what we could find in our races. Sometimes it's not categorized in our data, and so we have difficulty assessing what is the race based on our medical record. Again, is there anyone on our team who might be able to respond to that? Who should be on the Zoom?
Yeah, this is Amber Hyman. I can just say that it's based on self-reported race. So as Nikki said, if it's not recorded in the EMR, then we just don't have that available.
Great. I know a lot of people choose not to report their race, so I was just curious. My second question is, how long did you follow up on the newborns with what kind of antibodies they had in their blood for any length of time?
Well, we followed the infants for the outcomes through 1 year, 365 days of life. But with this, we did not take blood from the infants as part of the study, so we were not following antibody titers in these infants. This is
great. Thank you.
Safety study. Yeah.
Thank you. And we're going to move on to the next presentation. I did want to just acknowledge and thank Dr. Sylvester for his flexibility. So he will be presenting tomorrow since we are running pretty far behind schedule. And next we are going to move to Dr. Chip Walter from Duke University, who will be speaking about the safety of simultaneous versus sequential administration of the COVID-19 and IAV4 vaccines. If we could please switch the slide deck, that would be terrific. Thank you.
Good afternoon. So I'd like to thank the ACIP for the opportunity to present data from this study assessing the safety of simultaneous versus sequential administration of mRNA, COVID-19, and quadrivalent flu vaccines. Next slide. This is our standard disclaimer for presentations, and I'd like to acknowledge that this study was supported by the CDC's Clinical Immunization Safety Assessment Project. Next slide. Both influenza and COVID-19 vaccines are recommended for persons 6 months of age and older to prevent illness and complications resulting from these infections. Available data support the simultaneous administration of these vaccines. However, there are limited data from placebo-controlled studies evaluating the safety of simultaneous administration of influenza and mRNA COVID-19 vaccines. Next slide. Hence, we conducted a prospective randomized placebo-controlled observer-blind study to assess the simultaneous administration of these vaccines. Our study included non-pregnant persons 5 years of age and older if receiving a primary 2-dose mRNA COVID-19 vaccine series, or persons 12 years of age or older if receiving a booster mRNA COVID-19 vaccine dose. Persons also needed to be intending to receive a flu vaccine for that season. This study was conducted at 3 CISA sites: Duke University, Cincinnati Children's Hospital Medical Center, and Johns Hopkins University during the 2021, 2022, 2022, 2023 influenza seasons. At Visit 1, Day 1, we collected baseline health, demographic, and health-related quality of life information. Blood was also collected for COVID-19 serostatus. As depicted on the right, at Visit 1, participants received an mRNA COVID-19 vaccine, either dose 1 of the primary series or a booster dose, along with either IIV4 or a saline placebo as randomized. At Visit 2, on days 8 to 15, those who received IIV4 at Visit 1 received placebo, and those who received placebo at Visit 1 received IIV4. For those 65 years of age and older, high-dose IIV4 was used. At Visit 3A, conducted 27 to 57 days later, primary series participants received an mRNA COVID vaccine according to the recommended schedule for the respective COVID vaccine. Next slide, please. Our primary objective was to compare the proportion of participants with moderate or more severe fever, chills, myalgia, or arthralgia in the simultaneous group receiving IIV4 at the same time as mRNA COVID-19 vaccines at vaccination Visit 1, with the sequential group receiving IIV4 alone 1 to 2 weeks later at vaccination Visit 2. And this was following both vaccination Visit 1 and or Visit 2. 4 reactogenicity events reported at the moderate or more severe level were included in the primary statistical reactogenicity endpoint noted as RE. These included fever, chills, myalgia, or arthralgia, as these events were considered clinically meaningful. The primary outcome was considered to be present if a participant had at least one of the reactogenicity symptoms on at least one day during days 1 through 7 following Visit 1 and or Visit 2. We hypothesized that the proportion of participants with moderate or more severe fever, chills, myalgia, or arthralgia would be non-inferior or not higher in the simultaneous group versus the sequential group. Next slide. We had a number of additional secondary and exploratory objectives outlined in these next two slides. We wanted to compare the proportion of participants with the reactogenicity endpoint in both groups following each vaccination visit separately, describe the proportions of participants in each group of solicited local and systemic reactogenicity events according to severity grade after vaccination visits, and to describe proportions of participants in each group experiencing at least one serious adverse event and to describe these events. Next slide. We also aimed to further characterize and describe the proportion of participants in each group with local or systemic events of greater severity, describe the proportion of participants experiencing at least one unsolicited adverse event and one adverse event of special interest, and to further characterize these events. We wanted to compare, finally, the change in health-related quality of life from baseline in each group following vaccination visit 1. Next slide. After one-to-one randomization to either the simultaneous or sequential group, participants received study influenza vaccine or placebo according to assignment. Solicited reactogenicity and unsolicited adverse events were assessed on days 1 through 7 after each visit 1, 2, or 3A. Health-related quality of life was assessed by the Euroqual 5D5L and the Euroqual Visual Analog Scale at baseline and on days 1 through 7 after visit 1 only. Adverse events of special interest were assessed on days 1 through 121. These included multi-system inflammatory syndrome, Guillain-Barré syndrome, allergic type reactions occurring within 7 days of a vaccination visit, myocarditis or pericarditis. Serious adverse events per the standard FDA definition of an SAE were assessed on days 1 through 121. Bloods were drawn for immunogenicity, baseline, and post-vaccination. They were collected, but data are not yet available. Next slide. Our full analysis population 2, as we defined it, include all randomized and vaccinated participants. This population was used to describe characteristics and adverse event outcomes. Full analysis population 1 included all participants who were randomized, vaccinated, and provided at least 1 day of complete data on the symptom diary. This population was used to describe reactogenicity symptoms. Additional details regarding statistical testing are highlighted below. Next slide. So in all, 348 people were assessed for eligibility with 13 screen failures. 335 people were then subsequently randomized, 169 to the simultaneous group and 160 to the sequential group, which comprised this population. One person voluntarily withdrew in the simultaneous group, leaving 168 persons in that group, which was in the full analysis population. The next slide, please. Slide 11 describes here our enrolled study population. The population was more female than male, was 70% white, 6% Hispanic, and was largely 18 to less than 65 years of age. After randomization, there was some remaining imbalance in sex with a higher percentage of males allocated to the simultaneous group. The breakdown of enrollment by site is also noted. Next slide. More participants enrolled during the 2022-2023 season than in the 2021-2022 season. Just over 3% of participants received Moderna as opposed to Pfizer vaccine, with most participants receiving the Pfizer bivalent vaccine. Only 4% participants, all allocated to the simultaneous group, had not received a prior COVID vaccine. Therefore, most all participants were receiving a booster dose of COVID-19 vaccine. Consequently, we won't be discussing reactogenicity after visit 3A. Over half the participants had a prior COVID illness or a positive nucleocapsid antibody test at baseline. Next slide. So getting to our results, here, the proportion of persons reporting the reactogenicity endpoint of moderate or greater fever, chills, myalgia, or arthralgia was higher in the sequential group at 31% than in the simultaneous group at 25.6% when considering both vaccination visits 1 and 2. The rate of moderate or more severe fever, chills, myalgia, or arthralgia in the simultaneous group was considered not worse or not higher than the rate in the sequential group, and thus the non-inferiority criteria were met. The upper limit of the 95% confidence interval of the difference for the simultaneous minus the sequential group was 4%, and the non-inferiority margin was designated as 10%. Therefore, the null hypothesis of inferiority was rejected. Next slide, please. So we then looked at this same reactogenicity endpoint at vaccination visit 1 alone, and the percentage reporting ranged from approximately 24% in the simultaneous group to 28% in the sequential group, and no significant difference was noted between the two groups. Next slide, please. Looking at this same reactogenicity endpoint after vaccination visit 2 alone, the percentages reporting were overall much lower than after visit 1, ranging from 3 to 5%. And again, no statistical significant differences were observed between the groups. Next slide. So in this next series of slides, we take a more granular look at the proportions of participants in each vaccination group reporting reactogenicity events by severity grade within 1 to 7 days following vaccination visits 1 and 2. In these slides, the color green is a mild reaction, blue a moderate reaction, and yellow indicates a severe reaction. Overall, there were no life-threatening or grade 4 local or systemic reactions reported. Most reactions were mild or moderate and resolved within a few days. So on this slide here, reports a local reactogenicity at visit 1, with COVID vaccination being represented on the left and influenza vaccination site represented on the right. Overall, a larger number of local reactions were reported at the COVID vaccination site, as one might suspect, compared to the flu vaccination site. At the COVID vaccination site, no differences in the occurrence of local injection site reactions were noted between the groups. However, when considering just moderate or greater severity events, a larger proportion of participants in the sequential group reported moderate to severe pain and swelling. At the flu placebo site depicted on the right, more pain and axillary swelling occurred in the simultaneous group who received the flu vaccine compared to the sequential group who received placebo, with more in the simultaneous group also reporting pain at the moderate to severe level. Next slide. So this slide, slide 17 here, reports local reactogenicity after visit 2 at the flu placebo site. So a higher percentage in the sequential group receiving flu vaccine reported pain and swelling and axillary swelling and tenderness, with more in the sequential group also reporting pain and axillary swelling and tenderness at the moderate to severe level. Next slide, please. Slide 18 reports systemic reactogenicity after visit 1. No differences between the groups were noted for the reporting of any systemic reaction or reporting of a systemic reaction at the moderate to severe level. Slide 19, next slide. This reports systemic reactogenicity after visit 2. Overall, systemic reactions were less and were generally milder in nature at visit 2 when compared to visit 1. A higher proportion of people in the sequential group receiving flu vaccine compared to the simultaneous group receiving placebo reported chills, fatigue, myalgia, and diarrhea, but there were no differences between the groups for these systemic reactions at the more moderate to severe level. So now I'm going to move on with the next slide to reporting serious adverse events, and adverse events of special interest. So as you can see in slide 20, we had one reported serious adverse event occurred in each group, with no statistical difference in the occurrence of SAEs noted. The next slide, we'll talk a little bit about what those events were. In the sequential group, we had a participant with a past medical history of cancer and multiple abdominal surgeries, was hospitalized with an incarcerated ventral hernia and a small bowel obstruction 14 days following enrollment. And this event was deemed as unlikely related. In the simultaneous group, we had one participant who had a spontaneous complete abortion at 16 weeks gestation, which was 19 weeks following enrollment. This person also reported having a COVID-19 infection at 9 weeks following enrollment. This participant did not report being pregnant or having intention of becoming pregnant at enrollment. So the spontaneous abortion ultimately was deemed unrelated to vaccination. Next slide. We had 29 unsolicited adverse events were reported in 21 participants in the simultaneous group within 7 days of vaccination, whereas 16 events were reported in 16 participants in the sequential group within 7 days of vaccination. Again, there was no statistical differences between the groups in the proportions reporting an adverse event. Next slide. We had 28 adverse events of special interest reported during the study period, with 27 being the occurrence of a COVID-19 illness and 1 allergic type reaction. There was no statistical differences in the occurrence of an adverse event of special interest between the two groups. Next slide, please. Lastly, there were no differences between the groups in the health-related quality of life as measured by the EQ5D5L index or the VAS scores during the week following visit 1 for all participants. So all participants is represented by the top 2 lines in each of these graphs with the dots. And for those who experienced grade 3 reactions, and they were represented by the 2 lines beneath with squares. For those with grade 3 reactions, actually the EQ5D5L index did decrease from 0.92 pre-vaccination to about 0.8 by day 2 and recovered to baseline by day 3 to 4. For those with grade 3 reactions, the VAS score decreased from around 90 pre-vaccination to about 66 by day 2 and recovered to baseline by day 4. Next slide. Our study did have several limitations. Most data came from the use of bivalent Pfizer mRNA vaccine during 1 season, and there was very little use of the Moderna COVID-19 mRNA vaccine. Unfortunately, we enrolled very few children, ages 5 to 11, and older adults as well. the study was too small to detect rare adverse events, and people known to be pregnant were not included. A future CISA study will be assessing the safety of simultaneous flu and COVID-19 vaccine during pregnancy. Next slide. In summary, simultaneous administration of flu and mRNA COVID vaccines is well tolerated when compared to sequential administration. The occurrence of moderate or more severe fever, chills, myalgia, or arthralgia was not higher in the simultaneous versus the sequential group. We saw no differences between the groups in the adverse events occurring within 7 days, adverse events of special interest, serious adverse events, and health-related quality of life. As previously observed in other studies, injection site pain and systemic reactions were associated with the mRNA COVID-19 vaccine and flu vaccines. Most reactions were mild or moderate. Most frequent injection site reactions after either vaccine were pain and axillary swelling and tenderness. The most frequent systemic reactions after COVID vaccine, with or without flu vaccine, were fatigue, myalgia, headache, chills, and arthralgia. Receipt of flu vaccine alone was associated with chills, fatigue, myalgia, and diarrhea. Next slide. In closing, I'd like to acknowledge the investigative team at the respective sites and at the CDC. Next slide. I think that's it. Thank you.
Thank you, Dr. Walters. This presentation is now open for questions. Dr. Paling.
So thank you, Dr. Walter, for sharing the results of the study. It's very important. And I wanted to ask just a quick question. Would you share what the placebo was? Thank you.
Oh, thanks for that question. Yeah, it was saline.
Ms. Bata.
Thank you, and thank you, Dr. Walter. I'm asking a similar question. What was the flu formulation? Was it just the standard dose influenza vaccine?
Yes, it was a standard dose. Well, for older adults, it was the high dose flu vaccine. For adults under 65, it was a standard dose flu vaccine.
Okay, thank you.
Which was largely either Flucelvax or Flucelvax.
Thank you. Are there any other questions for Dr. Walter? Dr. Sanchez.
Thank you for that presentation. And I may have missed it. Your study design was to receive in the sequential 1 to 2 weeks later. Do you know what was the time interval between the two in the study?
It's a good question. For most people, it was 2 weeks. Towards the end of the study, we actually modified it slightly to allow a 1 week interval. But for most, it was around 2 weeks.
And just so I understand this a bit, initially, both groups received the COVID vaccine. And then the sequential one was the second time around was, well, the first time it was COVID and COVID plus influenza, or later, 2 weeks later, 1 to 2 weeks later, was influenza.
The sequential group got COVID and placebo, and then 2 weeks later got flu. The simultaneous got COVID and flu at the first visit, and then subsequently got placebo 2 weeks later. So
in essence, and if I'm understanding this correctly, the group the simultaneous one versus the sequential, in other words, giving influenza, there was no added reactogenicity after giving it along with COVID.
That was, yes, that was our finding.
Okay, thanks.
Thank you. Dr. Long?
Oh, yes. Was the axillary swelling only in the arm and at the time of coronavirus vaccine? Or did it occur with influenza as well?
You know, so I was surprised by the rate of axillary swelling we saw after influenza as well. So, but we saw it after both vaccines.
I didn't understand a word you said.
Did you have another question? Okay, Ms. Bata, is your hand still raised? Just confirming.
I'll take it down.
Thank you. Thank you, Dr. Walter. I don't see any other hands raised. Thank you for doing this study. Actually, I really appreciate being able to see all of these studies because my assumptions turn out to be not true. So, because I had always had a different assumption about simultaneous versus sequential. So thank you for sharing that information with us. We will move on. Is there anything else?
No, that's fine. Thanks so much.
Thank you. We're going to move on to Dr. Ken Schmader, also from Duke University, who will be speaking about the safety of simultaneous vaccination with RZV and quadrivalent adjuvanted IIV4.
Hello, everyone, and it's my pleasure to present the results of our study that Dr. Lee nicely entitled there. So let's go on to the next slide. This is the disclaimer slide. And also, I'll mention I have no conflicts of interest, and it was also supported by the ACIP project. Next slide. The lead site is Duke, and I want to give a shout out to Chip Walker too, and Johns Hopkins is a contributing site, and also a shout out to Dr. Karen Broder as the PI for the CISA project. Next slide. Here's the rationale. Novel adjuvants are powerful immune stimulants employed in vaccine platforms to improve immunogenicity and efficacy. In recent years, the FDA has licensed several vaccines with novel adjuvants. And you all know that vaccines with novel adjuvants are more reactogenic than vaccines without adjuvants. Clinicians may opt to administer these vaccines simultaneously, so data are needed on the safety of the simultaneous administration of vaccines with novel adjuvants. And for older adults who want to avoid zoster and influenza, data are needed on the safety of simultaneous administration of the recombinant Zoster Vaccine or Shingrix and the Quadrivalent Adjuvanted Inactivated Influenza Vaccine, Fluad. Next slide. So here's the study design. It was a randomized observer blinded clinical trial, except the vaccine administrator was not blinded but did not participate in outcome evaluations. The participants were immunocompetent, cognitively intact, community-dwelling persons, age 65 and older, who had not received that season's flu vaccine or prior receipt of RZV. They enrolled at Duke and Hopkins during the 2021-22 and 2022-23 flu seasons. Participants were randomized 1-to-1 to receive either RZV in the adjuvanted flu vaccine or RZV in the high-dose flu vaccine, that is Fluzone high dose. With the study visits summary, you see there, day 1, they received RZV dose 1 and either flu vaccine simultaneously. So RZV went in one arm, flu vaccine in the other arm. Day 60, they got the second dose of RZV, and we went through day 103, collecting safety outcomes. Next slide. So we had an intention to treat population defined as all subjects who were randomized and vaccinated, and a modified intention to treat population, all subjects randomized, vaccinated, and provided at least 1 day of complete data on the symptom diary. Next slide, please. So 285 participants were assessed for eligibility. There were 17 screen fails, leading to 268 randomized participants. Now, the next boxes show Fluad and Fluzone high dose, but I remember for this slide and all that follow, it's actually RZV dose 1 and the respective flu vaccine, not the flu vaccine alone, all right? So on the left there, you see there's 130 in the Fluad group in the ITT and MITT population. And on the right, 137 Fluzone high dose in the ITT. There's one participant who had missing diary entries, so there was 136 in the MITT population of Fluzone high dose. Next slide. Here's the demographic summary. There were about 49% female, 92% white, 1% Hispanic, 66% 70 years and older. No meaningful differences between the two groups, and we did not do a good job at enrolling underrepresented populations. Next slide. So here's the primary objective: to compare the proportion of participants with at least one severe or grade 3 solicited local or systemic reaction to the event after RSV dose 1 in the RSV and adjuvanted flu group versus RSV in the high dose flu group. The hypothesis being the proportion of participants with at least one severe solicited reactogenicity event will be non-inferior, that is not higher, in the RSV and adjuvanted flu group compared with the RSV and high dose flu group. And we chose a non-inferiority margin of 10%, which we viewed as clinically meaningful. So it was a clinical judgment of that margin. Next slide. All right, let's get to some results. Here's the primary outcome: proportion of participants with at least one severe solicited local or systemic reactogenicity event on days 1 through 8 after RSV dose 1 in each study group. You can see in the fluad group, there were 15 grade 3 events, 11.5%. In the Fluzone high dose group, there were 17 grade 3 events, 12.5%. The difference of minus 0.9% has an upper bound of the confidence interval of 7%. So this met the non-inferiority objective with a 10% non-inferiority margin, upper bound less than 10%. Also, the confidence interval contains 0, so there's no claim of superiority here as well. So this is the heart of the study, our primary objective and outcomes. Let's go on to secondary objectives, the next slide. So we had 3. One was to focus on at least one severe local reactogenicity event after RSV dose 1 in the 2 groups. That was a non-inferiority analysis. The second was focusing on severe solicited systemic reactogenicity events alone after RSV dose 1 in the 2 flu groups. Also a non-inferiority analysis. And then the third was to compare the proportion of participants with at least one serious adverse event or adverse event of clinical interest after RSV dose 1 in the 2 groups, 2 flu groups through day 43, and describe these events. And this was a 95% confidence interval comparison, not a non-inferiority analysis. Next slide. So let's look at the results of these objectives. Here's the first one, focusing on local reactogenicity events. In the fluad group, there were 8 of these grade 3 events, 6.1%. In the Fluzone high dose group, there were 6 grade 3 events, 4.4%. And the difference was 1.7%, the upper bound of the confidence interval, 7.7%. Again, meeting the non-inferiority objective, the upper bound is less than 10%. And as before, the confidence interval contains 0, so there's no claim of superiority. Next slide. Here's the second of the secondary objectives, focusing on solicited systemic reactogenicity events of days 1 through 8. RSV dose 1 in the fluad group, 7 grade 3 events for 5.3%. Fluzone high dose group, 13 grade 3 events, 9.5%. Difference is minus 4.1%. The upper bound of the confidence interval, 2.4%. Again, meeting the non-inferiority objective. Upper bound is less than 10%. Again, the confidence interval contains 0, so there's no claim of superiority. Next slide. Here's some figures showing, first off, local reactions, depicting local reactions after RSV dose 1 and flu vaccine. Because the RSV was administered in one arm, that's on the left, and flu vaccine in the other arm on the right, we have data on each of these vaccines. In other words, the RSV on the left represents local reactions in the arm that received RSV, flu vaccine on the right, reactions of flu vaccine alone. Green is mild, blue is moderate, red is severe. Most of the reactions being mild to moderate. And you see side-by-side group comparisons for pain, swelling, and redness. I'll let you look at that. I can say there are no significant differences in the proportion of moderate to severe local reactogenicity events between the adjuvanted flu group and the high dose flu group. Now let's go on to the next figure, which is systemic reactions. This time the reactions represent the combined effect of RSV and flu vaccines together. We can't tease them out individually. As before, green is mild, blue is moderate, and red is severe, grade 3s. Again, side-by-side group comparisons for fever, chills, fatigue, myalgia, headache, arthralgia, nausea, vomiting, diarrhea, and abdominal pain. As before, there are no significant differences in proportion of moderate severe systemic reactogenicity events between the adjuvanted and high-dose flu groups. I want you to look at the slide of all the empty spaces above those figures. In other words, in the fatigue category, this represents people who had no reactions. In the fatigue category, 48 to 50% of individuals had no reactions despite receiving both vaccines simultaneously. In the myalgia category, 52 to 58% had no myalgias despite receiving both vaccines. It's quite interesting. All right, next slide. Let's move on to some SAEs. In the ITT population, here's the proportion of participants with at least one SAE, or adverse event of clinical interest after RSV dose 1 within 43 days. There were 6 of those subjects. In the flu-ad group, there was 1 SAE, 0.7%. In the flu zone high dose group, there were 5 SAEs, 3.6%. The difference is minus 2.8%, 95% confidence interval, 6.3 to 0.6 crossing 0, so that's not statistically significant. Next slide. This shows all subjects with 1 SAE throughout the entire study period. There are 9 of those subjects. In the flu-ad group, 4 SAEs for 3%. The flu zone high dose group, 5 SAEs for 3.6%. The difference minus 0.5%. Again, crossing 0, not statistically significant. All right, let's move on to the next slide. We'll describe these SAEs a little bit. Here's the list of SAEs within 43 days of vaccination. You see the flu vaccination group, the age group and years, relatedness according to study investigators, and clinical description. These all occurred between 21 to 41 days after vaccination. They all involved hospitalizations. There was a pacemaker due to arrhythmia, one labeled as numbness for cerebral vascular accident, hyperkalemia, shortness of breath, deep venous thrombosis, pulmonary embolism. And then the last there was a left partial cranial nerve 3 palsy. This occurred 25 days post-vaccination, and it was in the high-dose flu group that had an extensive neurology workup. We thought this was possibly related, but even after extensive workup, there was unknown cause. But the clinicians that did the workup and us thought, this conceivably could be immune-mediated. Let's go on to the next slide. And these are the SAEs after 43 days. There were 3 more of them, all thought to not be related: hepatocellular carcinoma, revision of right shoulder, rotator cuff surgery, and COPD exacerbation. All right, next slide. We also had these pre-specified adverse events of clinical or special interest. They were syncope during the post-vaccination monitoring clinic, and that did not happen. Anaphylaxis in the first 24 hours after immunization, that did not happen. And the last one is what we just talked about with that cranial nerve palsy. All right, next slide. We also had a similar exploratory objective to look at impact on health-related quality of life using the EQ-5D-5L and visual analog scale that Chip showed you a little earlier. For interest of time, I'm not going to go through all of this in detail, other than to say there was no significant differences between the groups, either in all participants or in those who had grade 3. And again, the similar drop in both the index and the self-rated health in the grade 3 participants alone that had a nadir at day 2 and got the baseline at day 4, which is kind of interesting. All right, next slide. So here are our limitations. The enrollment was limited by COVID-19, got about 70% of our target, although it didn't obviate the results for the primary and secondary objectives. As I mentioned, the study population was mostly white, not Hispanic, not enough individuals that are underrepresented populations. And an important point is the study is too small to detect rare adverse events. Next slide. So in conclusion, the proportion of participants with at least one severe local or systemic reaction was not higher after RSV dose 1 and the adjuvanted flu vaccine compared to RSV dose 1 in the high-dose flu vaccine. The frequency of moderate to severe local and systemic reactogenicity events were similar. The RSV dose 1 was administered with adjuvanted or high-dose flu vaccine. Few participants had SAEs during the study after RSV dose 1 was administered with adjuvanted or high-dose flu vaccine, and the clinical conditions were those expected in the population of older adults. So we're thinking from a safety standpoint, this study supports simultaneous administration of RSV and adjuvanted flu vaccine as an acceptable option for vaccine delivery in older adults. And that's the end of my presentation. And Dr. Lee, we're within 5 minutes of where we need to be. Thanks.
Thank you, Dr. Schmieder. I want to thank everybody for your very efficient presentations, and also just thank you for the work that you've done to share on safety and especially concomitant vaccines and in pregnancy. Dr. Talbot.
Hello, Dr. Schmieder.
Hello.
I love these studies. All right, so question of the day, which may not have been funded, but have been fabulous to see. Did you have antibody responses?
We definitely drew blood for HIV, HAI titers kit, and that's being analyzed right now.
Because it'd be interesting to see if those who had more severe reactions had better antibody responses. So
Yeah, absolutely. I know that's a favorite topic of ours. Yeah, absolutely.
I know. Being nerdy.
We will have some data on that.
Dr. Daly.
Thanks so much, Dr. Schmader. Can you remind us of how the investigators determine not related? Pick an example such as pulmonary embolism, and what are the characteristics that the investigators are looking for to determine that it's not related? Thank you.
Yeah, great question, Dr. Daly. And I think the two that we're really focusing on there was the neurological event, the numbness in CVA, and the cranial nerve palsy, which we did think was possibly related. The stroke was a soft call based on the data we got from the clinicians who were seeing that patient, but also it was temporal. That occurred 26 days after vaccination, and we were kind of thinking about that risk window of 1 to 21 days for stroke risk, like we had seen when Nikki Klein has presented the VSD-RCA analyses for the COVID vaccine for that stroke risk window. That was the reason, mostly temporal.
Any additional
And the
questions?
the pulmonary embolism?
Yeah, that was also well beyond 21 days.
Sorry, I didn't hear the response.
That was also beyond 21 days.
Any other questions, Dr. Daly?
No, sorry, I'll put my hand down.
Additional questions for Dr. Schmader? Okay, thank you. I want to thank all of our presenters in the flu vaccine session, and also so Dr. Klein, Dr. Walter, Dr. Schmader, and also thank you to Dr. Sylvester for allowing us to move his presentation till tomorrow. We are going to move on to one more vaccine safety update at the end of the day. Without further ado, I will turn it over to Dr. Tom Shimabukuro, who will be providing an update on COVID-19 and influenza vaccine safety.
Good afternoon. Today I'll be giving an update on COVID-19 and influenza vaccine safety. Next slide, please. So I'm going to start with a few key points up front, and just by way of background, a statistical signal for ischemic stroke after the Pfizer bivalent vaccine was detected in CDC's vaccine safety data link in persons 65 and older during the fall of 2022. And this information has been presented at prior ACIP meetings, and efforts have been underway to evaluate the signal. And today, I'm going to summarize the results of some of these post-signal analyses. Based on these post-signal analyses, we can conclude that the available data do not provide clear and consistent evidence of a safety problem for ischemic stroke with bivalent mRNA COVID-19 vaccines when given alone, or given simultaneously with influenza vaccines, or when influenza vaccine is given alone. And for the purpose of this presentation, influenza vaccine given alone means not with a COVID vaccine, but possibly with other vaccines. Variable and inconsistent results were obtained in some analyses of the risk of ischemic stroke following bivalent COVID vaccination, simultaneous bivalent COVID and influenza vaccination, and influenza vaccination alone. Most study results have not shown an association between vaccination and ischemic stroke, and no clear pattern demonstrating increased risk has emerged. It's important to keep in mind that any real or theoretical risks of vaccine adverse events need to be placed in the context of the known benefits of COVID-19 and influenza vaccination in preventing disease and their potentially serious complications, including stroke. And then finally, our vaccine safety monitoring systems are designed to be sensitive, and the detection and assessment of potential safety signals and communication of safety information to the public is an example of the vaccine safety monitoring process working. Next slide. So I'll be providing a summary of some of these analyses of ischemic stroke and bivalent mRNA COVID-19 vaccination and influenza vaccination. I'll mention some additional data on ischemic stroke and then wrap up with interpretation and next steps. Next slide. So this is just a listing of the selected analyses of ischemic stroke and bivalent COVID-19 influenza vaccination. And on the next slides, though, they're numerically ordered to correspond with the list here. Next slide, please. So this is the first data that you heard about this signal. This is the VSD COVID-19 rapid cycle analysis of ischemic stroke after Pfizer bivalent booster dose. The data source is the VSD data contributing sites. The methodology, the primary methodology was a vaccinated concurrent comparator. That's looking at bivalent vaccinated people compared to other bivalent vaccinated people, using a 21-day risk interval and a 22 to 42-day comparison interval. The supplemental analysis was a bivalent vaccinated versus bivalent unvaccinated but eligible for bivalent vaccine in a 1 to 21-day risk interval. So this looked at vaccinated versus unvaccinated but similar to the vaccinated because they were eligible for a bivalent, and comparing stroke in the 21-day risk interval in these two groups. And the age groups were 18 to 64 and 65 and older. The main findings were a statistical signal for ischemic stroke detected in the primary analysis after Pfizer in the age group 65 years using a 1 to 21-day risk interval. And this signal attenuated over time as we accumulated more data. A post-signal assessment detected an elevated risk in the age group 65 and older receiving same-day Pfizer and a high dose or an adjuvanted influenza vaccine, and this finding also attenuated over time as more data accumulated. There was no elevated risk for ischemic stroke detected in the supplemental analysis using secondary comparators. An additional supplemental analysis suggested that the comparison interval rates of ischemic stroke were lower than expected. Next slide. This is a study, ischemic stroke after bivalent COVID-19 vaccination, a self-controlled case series study that was conducted by Kaiser Permanente, Southern California. It was conducted through an NIH grant. So this is separate from the VSD, although Southern Cal is a VSD site. This was a separate analysis conducted independently by Southern California, and it used their electronic health record data. It was a modified self-controlled case series using age groups 12 and older, 12 to 64, and 65 and older. The main findings, there was no elevated risk detected for either the Pfizer or Moderna vaccines in any age groups in the automated data with a 21-day risk interval. There were no elevated risks detected for either Pfizer or Moderna in the age group 65 and older in automated data with a 42-day risk interval. There were several analyses with statistically significant elevated risks in the age group 12 to 64 years in automated data with a 42-day risk interval. For Pfizer, this was in Pfizer with simultaneous influenza vaccination, both overall and in those with a history of SARS-CoV-2 infection, and in Moderna, those with a history of SARS-CoV-2 infection. Those were the strata in which these statistically significant findings were observed. But after limiting signaling analyses to chart verified cases, the findings were no longer statistically significant. Next slide. This next study is an FDA-sponsored study evaluation of stroke risks following COVID-19 mRNA bivalent vaccines among U.S. adults aged 65 and older. The data source was Medicare claims data. Populations were community dwelling Medicare beneficiaries aged 65 and older. The primary population were recipients of bivalent COVID-19 vaccines. The secondary population were recipients of a high dose or adjuvanted influenza vaccine. The methodology was a modified self-controlled case series with Farrington adjustment. As far as the main findings in the primary population analysis, did not show any consistent stroke risk after mRNA COVID-19 vaccination. An increased risk was observed with concomitant or same-day administration of influenza vaccination. And these findings were for non-hemorrhagic stroke after Pfizer and high-dose or adjuvanted vaccine with a 22 to 42-day risk interval, and transient ischemic attack after Moderna and high-dose or adjuvanted with a 1 to 21-day risk interval. Secondary population analyses showed a small increased risk of non-hemorrhagic stroke after high-dose or adjuvanted flu vaccines with a 22 to 40-day risk interval, and the risk remained for people without concomitant bivalent mRNA COVID-19 vaccination. Next slide. This next analysis was ischemic stroke after COVID-19 bivalent vaccine administration in patients aged 65 years and older, an analysis of nationwide patient electronic health records in the United States. The data source was the TriNetX system, which is a cloud-based analytics platform that includes electronic health record data on over 90 million unique patients in the United States. This was a retrospective cohort study among people aged 65 and older. And the main findings were patients who received bivalent Pfizer vaccination had a similar hazard for ischemic stroke encounters compared to those who received bivalent Moderna vaccination, but had a lower hazard ratio than those who received the monovalent Pfizer or Moderna booster vaccines in the 1 to 21 or 22 to 42 days post-vaccination. Next slide. This next study is a study out of France: stroke, myocardial infarction, and pulmonary embolism after bivalent booster. The data source was the French National Health Data System linked to the National Coronavirus Disease Vaccination Database. It was a matched cohort study, 1 to 5, in people aged 50 and older. A recipient of a monovalent vaccine was matched to recipients of bivalent mRNA COVID-19 vaccine, and these individuals were followed for 21 days after vaccination. The main findings were compared to monovalent Pfizer vaccination. Bivalent Pfizer vaccination was not associated with an increased risk of ischemic stroke, hemorrhagic stroke, myocardial infarction, or pulmonary embolism in people aged 50 and older. And the authors previously found no increased risk in the incidence of stroke, acute myocardial infarction, pulmonary embolism, or pulmonary embolism after administration of the monovalent Pfizer vaccine. Next slide. This next study is out of the UK. It's a BA1 bivalent COVID-19 vaccine use in stroke in England. The data source was the National Health Service hospital admissions in England linked to the National Immunization Management System. It was a self-controlled case series in people aged greater than 50 and older and 65 and older, using a 1 to 21 day risk window, with further analysis in people aged 65 and older given simultaneous bivalent mRNA COVID-19 vaccine and influenza vaccination. The main findings were no increased risk of stroke in the 21 days after vaccination with either the Pfizer or Moderna bivalent mRNA vaccines. Similar results were obtained for ischemic and hemorrhagic stroke for the subset of people aged 65 and older given influenza vaccine on the same day as the bivalent mRNA COVID-19 vaccines. Next slide. The last study I'll present is out of Israel. Safety of monovalent and bivalent Pfizer mRNA COVID-19 vaccine boosters in at-risk populations in Israel, a large-scale retrospective self-controlled case series study. The data source was the Clalit Health Services medical records, which is the largest healthcare organization in Israel with over 3.5 million enrollees, 1.2 million of which are age 60 and older. It was a self-controlled case series. The main findings were no safety signals detected for ischemic stroke after either monovalent or bivalent Pfizer COVID-19 vaccine used in Israel in the overall analysis or in people aged 65 and older. Next slide. So I know that was a a lot to unpack as far as these additional analyses, but I just want to remind you of some additional data on ischemic stroke. There were no unusual or unexpected reporting patterns observed and no evidence of a safety concern detected for ischemic stroke with either the bivalent mRNA COVID-19 vaccines in VAERS monitoring. FDA monitoring in the CMS data and VA monitoring in the VA system did not detect any safety signals for ischemic stroke following bivalent mRNA COVID-19 vaccination using historical comparator designs. A separate ad hoc CDC analysis during the bivalent Pfizer ischemic stroke signal assessment did not detect an elevated risk for ischemic stroke after influenza vaccination alone. Surveillance conducted by international regulatory and public health partners did not detect a safety concern for ischemic stroke following bivalent mRNA COVID-19 vaccination. There was no evidence of a safety signal for ischemic stroke detected in the manufacturer's global monitoring of bivalent mRNA COVID-19 vaccination, and no safety signals were detected for ischemic stroke for primary series or monovalent boosters for Pfizer or Moderna vaccines in US and global monitoring. And data suggests COVID-19 and influenza disease are associated with an increased risk of stroke, and this was previously presented at an ACIP meeting. Next slide. So I want to show some data on disease because I think it's important in the context of these findings. So this is a graph that's actually taken from the FDA study that I summarized previously this is monthly incidence rates of non-hemorrhagic stroke in Medicare claims data, which suggests seasonality. And there are other data that actually show this pattern of seasonality, but this is fairly recent data. And as you can see, incidence tends to be higher in the winter months, then dips down in the summer months, and then starts creeping back up in the fall. And like I said, this pattern has been observed in other analyses, and this is some indirect evidence of a possible correlation with circulating viral respiratory pathogens. Next slide. So I want to, this next slide shows a graph of some data for outpatient visits for respiratory illness in the United States from ILINet. And on the y-axis, it's the percent of these visits which are for ILI. And I think one thing that's important to notice, this shows multiple seasons, but one thing that's important to notice, if you focus on the 2022-2023 season, which is the orange line, this is the most recent season, you'll see that there was what seems to be a relatively potentially severe relatively severe ILI season, which had a fairly sharp peak compared to some of these other seasons and peaked early. So that kind of tells you what happened, this past season with respiratory illnesses, at least what we can gather from outpatient visits in ILINet. Next slide. I'm sorry, can you go back to the previous slide? So the next slide, please. I'm sorry, the graph with the color, kind of the color-coded graph. One thing I want to mention, just to provide some context for why I'm showing this, and there is some evidence that infection is associated with stroke, particularly with COVID-19 and flu. So I think we think it's important to also consider respiratory illness and viral illness when looking at these vaccine safety data. Next slide. So moving on to interpretation, our interpretation of these of the data that I just presented from these post-signal analyses after the initial RCA finding was, there's variable and inconsistent results that were obtained in some analyses of the risk of ischemic stroke following bivalent COVID-19 vaccination, simultaneous bivalent COVID-19 and influenza vaccination alone. There is a lack of consistency in findings from different data systems when using different methods across age groups and across subgroup analyses. The most common findings across the studies are a finding of no association. Multiple comparisons were conducted in studies while adjusting for multiplicity, and few of these reached statistical significance. The studies were not designed to account for the potential protective effect of vaccination on stroke and later post-vaccination periods. Adjusting for seasonality and restricting analyses to chart-verified cases frequently resulted in attenuated findings or findings that were no longer statistically significant. The remaining statistically significant findings tended to be relatively small in magnitude, and ischemic stroke cases in the analyses are predominantly occurring in older people and in people in the upper ranges of the age group studied, meaning there are relatively few cases in younger people. Next slide. So the available data do not provide clear and consistent evidence of a safety problem for ischemic stroke with bivalent mRNA COVID-19 vaccines when given alone or given simultaneously with influenza vaccines, or when influenza vaccine is given alone. Most study results have not shown an association between vaccination and ischemic stroke, and no clear pattern demonstrating increased risk has emerged. Seasonality of stroke risks and an unusual respiratory illness pattern in 2022 and 2023 could be impacting the results of some of these analyses, and unrecognized SARS-CoV-2 infection could also play a role in occurrence of stroke after vaccination. It's important to recognize that any real or theoretical risk needs to be placed in the context of the known benefits of COVID-19 and influenza vaccination and preventing COVID-19 and influenza disease and their potentially serious complications, including stroke. Simultaneous vaccination provides substantial benefits in keeping patients up to date with recommended vaccines and protected from vaccine-preventable diseases. And our vaccine safety monitoring systems are designed to be sensitive and the detection and assessment of the ischemic stroke signal and communication to the public is an example of the vaccine safety monitoring process working. Next slide. So our next steps, we'll conduct additional analyses on the possible relationship between ischemic stroke and bivalent mRNA COVID-19 vaccination. Simultaneous administration of bivalent mRNA COVID-19 and influenza vaccines and influenza vaccine alone. We'll continue vigilant safety monitoring of the 2023-2024 COVID-19 and influenza vaccines, including for ischemic stroke. And we will be happy to come back to the committee and brief you when we have additional safety data. Thank you. That concludes my presentation.
Thank you, Dr. Shimabukuro, for that excellent presentation. Dr. Lair.
I'd also like to say thank you very much for that presentation. Could we go to slide 7? A little bit of context. The flu work group heard about the FDA study, which is on slide 7 here, and there were some concerning findings. And so that was about 2 weeks ago. Last Monday, so 2 days ago, the presenter gave us a little bit more detail about this, and the work group asked for context and a presentation today. So this all came together from Dr. Shimabukuro in 48 hours. And I really appreciate that detail and the perspective of all the studies, not just the one study that came out 2 weeks ago. So I feel like I have a much better context of the vast number of studies which are suggesting that there is not a consistent pattern of concern. So thank you very much for your very hard work.
Dr. Daly.
Yeah, Matt Daly here, and I had a similar observation to what Dr. Lair just said. So I'm going to sort of expand upon that a little bit. But, I think vaccination programs and vaccine safety monitoring has taught all of us to be quite humble. And by that I mean there have been circumstances where I heard something at first that seemed fairly implausible. In a susception following an oral rotavirus vaccination, the first time I heard of that. And And then also, frankly, myocarditis. The very first time I heard that, I thought that seems unlikely. Dr. Shimabukuro, if you could go to slide 16. I think this is one of the best examples of integrating multiple data sources, multiple platforms, multiple study designs, and then helping us interpret this both for ourselves and for the public. What it shows is, as you concluded, a vaccine safety monitoring system that is working and working well, even though we all recognize, first of all, this is complex. Second of all, we need to be humble. And by that, I mean expect the unexpected. And third, that we design a system to be sensitive. And what that means is cast a wide net, right? And I realize that's hard to explain sort of to the public, but when you cast a wide net, then that may mean that there are things that turn out to be what we'd call a false positive signal. And this is really in contradistinction and in distinction to what we found with myocarditis, which was, again, that's a rare adverse event, but when we looked in multiple systems, it was consistent across those systems, consistent in its timing, consistent in which vaccines, consistent in which dose, and this is really very different from what we're seeing here. So again, a little bit of elaboration, but mainly I really appreciate the ability to bring all this to the committee, full transparency, and then help us understand it. Thank you.
Thanks. Just to build off what you just said, Dr. Daly, we have multiple complementary systems that work in different ways and use different methods, both within CDC and across the federal government with our partners such as FDA, VA, and Department of Defense. And our systems are, as you said, designed to be sensitive, to be able to rapidly detect and assess potential safety problems. And we strive to be timely and transparent in our communication of safety information. And I agree with you that consistency of findings across different systems using different methods is important and tells us something about a potential adverse event. And the myocarditis signal is a great example of where all the evidence from multiple systems in the United States and outside, we're all pointing to a common finding. And I think this is a much different situation than myocarditis.
Any other questions? Well, I just want to also, again, add my thanks to Dr. Shimabukuro for adding clarity when oftentimes it feels like there's a lot of uncertainty. I also want to just emphasize that we've spent the last half of this day focused on vaccine safety as a topic of great interest, and also that the ACIP as a committee is committed to continuing to review the benefit risk balance in real time and always come back and revisit decisions. Recognizing that as things change, our decisions must also change. But I will just say out loud that given the totality of the data that you presented today, I feel very comfortable with our current recommendations rolling forward. And, as we're going into this respiratory season, and I don't know if some of you are also experiencing slightly higher upticks these weeks with hospitals feeling more full, I'm very grateful to have the opportunity to have vaccines to prevent much of this illness. I do think things will start to look very different in the next year or two, the more we're able to tackle disease. The final thing I did want to mention, and actually you brought it up, Dr. Shimabukuro, is I do think, for ACIP, we obviously focus on the vaccine preventable illnesses, typically as what our focus is, but COVID-19 has taught us that there are longer term effects of some of these infections, and preventing infections not only maybe prevents that acute illness, but perhaps provides longer term protection and more than we realize. So akin to your comment that the respiratory viral infections have a seasonality, we noticed that many of these serious illnesses, stroke, myocardial infarction, other outcomes also have some seasonality and can be associated or triggered by an initial respiratory illness. I do think we undervalue these vaccines and the impact they actually have on the health of the individual. So would just encourage us to continue to not only rigorously pursue safety from a broad scale perspective, but also continue to look for opportunities to better understand the longer term impact of these vaccines on the health of populations, because I think it is far greater than what we think. Are there any other questions from the room or online? Okay, I don't see any hands raised. I want to thank our flu team for getting us over the finish line and getting us to finish on time and even slightly early today. Again, thank you to our colleagues for the entire day. We've had a complicated set of discussions, and it's been, I really appreciate my colleagues for making sure that we have a robust set of discussions and are continuing to ask questions to ensure our decision-making is sound. And with that, I think we will end for today, and we'll plan to reconvene again tomorrow for our day 2 of ACIP meeting. So thank you, everyone, and have a good evening.